Good evening, everyone. On behalf of the Lamb Foundation, it is my pleasure to welcome you all to our Lambposium in Your Living Room Circle of Hope Transplant Support Program webinar. We have a unique evening planned for you with the patient voice and experience at its heart, as you just heard from Barb, which is very exciting. I'm so glad you could join us. My name is Cindy Beasley. I am the Director of Education and Advocacy for the Lamb Foundation. And with me tonight are Karen Kinsey, our Circle of Hope coordinator, as well as patient panelists Marla Hamlin, Rhonda Officer, Lisa Pascal, and Susie Picard. Please note that this evening's session is being recorded and will be available on our website next week. So before we get started, I'd like to take a moment to recognize and thank our sponsor, the National Disease Research Interchange, or NDRI. NDRI is a not-for-profit organization with over 40 years of experience in supporting the advancement of biomedical research through facilitation of human organ and tissue donations to the scientific community. If you are a Lamb patient living in the U.S. and are having an upcoming surgery of any kind, please reach out to the Lamb Foundation for information on how you can donate tissue through our partnership with the NDRI. It is a simple process with exponential impact. And now it is my pleasure to introduce you to this evening's moderator, Karen Kinsey. Karen is our Circle of Hope Transplant Support Program coordinator. Residing in Northern Virginia, just outside of Washington, D.C., Karen was diagnosed with LAM in October of 2002 and received a double lung transplant in January of 2023. A longtime patient advocate and supporter of the Lamb Foundation, Karen brings wisdom and compassion to her position and the patients she serves. Karen, I will now turn our program over to you.
Thank you, Cindy. Welcome, everyone, and thank you for joining us tonight to hear our four panelists address the topic, Things I Wish I Had Known Before Transplant. I will begin tonight's webinar with a broad overview of organ transplantation, followed by a quick bio of each of our panelists, then have each panelist share their perspective on a key area concerning transplantation. We hope to open the Q&A by 7:45 to allow for much discussion. Please note that the chat box will be disabled until each panelist has shared her focus for tonight's webinar. We will end the Q&A at 8:25 Eastern Time, at which Cindy will rejoin us to wrap up the webinar, allowing us to finish by 8:30. As an overview, I want to share this graphic of the human body, illustrating the complexity of three of the systems in our body, the vascular system, the nervous system, and the skeletal system. The simple act of breathing involves several body systems working together, the three that I have already mentioned, as well as the respiratory system and the muscular system. Because of the interaction and coordination of numerous systems and organs, lung transplantation involves much more than simply replacing unhealthy lungs with healthy ones. For instance, post-transplant, the team will not only test your spirometry, but also test your ability to swallow and continuously check your kidney and liver functions. Because of the significant medical advances today, organ transplantation is a viable, life-saving option for many. As of December 4th, in the United States, there were more than 108,000 candidates on the wait list for an organ. As you can see from the slide, over 94,000, which is more than 85%, were on the list for a kidney. In comparison, there were 984 candidates, or less than 1%, on the wait list for lungs. Looking at the candidates listed for lung transplant, we see that there are 3 patients listed diagnosed with LAM who are currently on the wait list. Should a candidate be listed for a second or third lung transplant, they would not be listed by their disease type, but be listed under the category lung retransplant. Simply put, as you know, LAM is rare, and lung transplantation for those diagnosed with LAM is rare. Year to date, there have been 10 Lammies who have received lung transplants, and 1 Lammie who has received a heart transplant. Before I introduce our four panelists, I want to share that, in my opinion, lung transplantation is both an art and a science. It is important to understand that the lung transplantation evaluation process, the guidelines, the post-transplant protocols can and do vary across the 64 lung transplant centers in the United States. And now it is my pleasure to introduce our four panelists for tonight's webinar. They are Susie Picard, Marla Hamlin, Lisa Pascal, and Rhonda Officer. As a brief overview, Susie's first LAM symptom, a pneumothorax, occurred in 1989. Her LAM diagnosis came 12 years later, and her transplant followed 23 years later. In just a few days, Susie will be celebrating her first lung anniversary. Congratulations, Susie, on this incredible milestone. Now we move on to Marla. Marla's first LAM symptom, also a pneumothorax, occurred in 1992. Her LAM diagnosis came 6 years later, and her transplant followed 13 years later. Lisa's first symptom, a pneumothorax, occurred in 1986. Her LAM diagnosis came 14 years later, and her transplant came 14 years later. And as a reminder, she was on the waiting list for a transplant for 3 years. And Rhonda, her first LAM symptoms, including shortness of breath, occurred in 2001. Her LAM diagnosis came 6 years later, and her transplant followed 11 years later. At this time, I am pleased to introduce Susie, who will talk about medications and their side effects.
Hello. So yes, this first year has just gone by so quickly. I can't believe it. I'm looking at 1 year here in just a couple of days. Um, I wanted to say that when I was diagnosed back in 2001, I was told that because that LAM was so rare, I will probably never meet another person who has LAM. And so here we are years later. And, of course, that was not true. It turned out to be I've made a lot of friends and known a lot of people. So thanks to the LAM Foundation in particular. So when I came out here to North Carolina, I live in North Carolina near Duke, which is in Durham, North Carolina. I came out here in part, we got a job out here because we knew that I ultimately might need a transplant. This was before sirolimus was available. And I had the opportunity because several LAM patients had their transplants here at Duke. I had the opportunity to accompany them to their appointments and to learn a lot about what the transplant process involved. So in that sense, I was really lucky because I live here. And then just through LAMIs and the LAM Foundation and getting to know people, that's really helps a lot to be able to ask questions. So I felt really kind of confident going in to transplant. I was strong and I knew about what to expect and the pre-transplant requirements and what the medication names were. And I just felt like, I got this, but then when transplant came, there were several things I just wasn't as prepared as I thought I would be. And so I'm going to talk today a little bit about the medications and their side effects and some of these things that kind of threw me for a loop. So as on the slide there, the medications, well, first let me back up and say you get a lot of medications and the doctors will work with you. There are anti-rejection drugs and there's kind of standard ones, but everybody's different. You metabolize drugs differently. You have different medical issues. Somebody may have diabetes, somebody may have heart issues, whatever. The drugs, they'll work with you and tweak those medications, especially the first year. And your doses may go up and down, and they can give you alternatives if something doesn't work. So just know in advance that the medications can change and probably will change over time. So before transplant, I had a really, I guess like you'd call it an iron stomach, and I did well with meds, and I didn't expect to have any issues, but they kind of threw me for a loop, and I had a lot of stomach aches and nausea and cramping and GI issues. So that was one issue that I had that I wasn't expecting. Um, the medications can mess with your sleep. They gave me um, basically gave me insomnia because I got upset about not being able to sleep. I was like, why can't I fall asleep? I used to sleep, you lay down, you fall asleep. And I still struggle with that. But some of the medications can be stimulating or just disturb your sleep. So that is something I wish I'd known in advance. So maybe I wouldn't have gotten kind of so bent out of shape about not sleeping well. Um, Prednisone is a drug in particular. It's used to reduce inflammation. And initially, you're on very high doses right out of transplant. And the prednisone can have a lot of side effects. It can affect your skin. It affects your insulin, and some people develop diabetes afterward, which can be temporary. The prednisone can make you gain weight. It causes redistribution of fat, and so you have changes to your appearance, especially, the rounder face, they call it the moon face. And that does change over time as your prednisone dose drops. So it gets better. um, so the thing I didn't know about prednisone was its impact on your muscles. So I was pretty strong physically going in. I mean, I tried hard to build my muscle strength because I'd been told to do so. And afterward, the drugs, you're kind of sedentary, and the prednisone actually inhibits the proteins or muscle growth. So it makes it hard, right? So if you lose weight, as I did post-transplant, and if you lose muscle mass, the prednisone can work against you. You have to work really hard to try and stay strong and eat a lot of protein, maybe drink protein shakes. I mean, those are things that I wasn't aware of. And I struggled with gaining my strength back after transplant because of that. The other drug that we mentioned on here on the slide is tacrolimus, and this is also an anti-rejection drug. And it has a lot of side effects as well. In particular, you can have your hands shake or your, uh, extremities shake, just tremors. When the doses are high, the tremors can get worse. It caused for me, and it doesn't do this for everyone, but I lost a lot of hair, and it took about, well, my hair started growing back now, thank goodness, but it took about 10 months. So that can be, kind of disturbing. I mean, you're really so grateful to be able to breathe, but having the changes like from the prednisone, causing your face shape or your body, the fat distribution to change, and then the hair loss, it's like, it's kind of startling. So you're happy that you're doing well, that you look in the mirror and it's like, who is this person? So I wasn't really prepared for that. What else did I want to talk about? I guess one of the things I wanted to mention was that I was told in advance that it would take a year to recover. Most people, it takes about a year. And I thought, because I was so strong going in, that won't be the case for me, I don't know, that was delusional maybe, but I really thought I would do better. And so psychologically, it was kind of hard for me to have lingering side effects, of the problems with the meds and the trouble regaining my strength. So I think it would have been helpful to know to be more patient, especially, when I really just thought I could power through it, but your body takes time to heal. So you have to be patient and give it time, and, it gets better. Um, I think I turned a corner around 3 or 4 months, and, it's slowly, it's gotten better. it's helpful to seek out other patients, people, Lammy friends who had their transplant and ask them questions. That's just a gold mine of information. So that's basically what I was going to share.
Oh, Susie, thank you very much. That you've touched on a lot of important points, and I agree with you. So thank you. I'm pleased to introduce Marla, who will share her thoughts on the importance of healthy eating and exercise. I'm shocked that that's what you picked to talk about, Marla.
Yeah, well, a lot of people who know me, I know it's hard to believe, but at one time after my diagnosis, I weighed 204 pounds. In fact, yes, I did. In fact, I got yelled at by a lady at pulmonary rehab because I got on the 200 pounds over treadmill. And she's like, "You don't weigh that much. You can't get on there." And I go, "I weigh 204. So, haha, too bad." But I was in oxygen 12 years. I started with 2 liters and then I got up to 15 liters for the last 2.5 years while I was waiting. But I was grateful to my pulmonologist because he did start me in pulmonary rehab right after my diagnosis. I was 42 at the time. And I just felt that was so important to start an exercise program. You know, if you can't get into pulmonary rehab, just walking. I mean, I used to have so many lung collapses and lung surgery before I even knew I had LAM, and I would walk around the house. And one thing that I learned through pulmonary rehab was doing weight bearing exercises. I always had a free weights at home, whatever. Once I got listed, I my goal was to be as strong as Susie talked about, be as strong as you could. So I would work out 5 to 6 days a week. And at pulmonary rehab, we were allowed to pay to work out. So they let me attach to the wall. And because I didn't retain carbon dioxide, which I don't know if you have to do those wonderful ABGs where they stick you and it hurts sometime if you don't get a good one. Um, I did not retain carbon dioxide, so they could turn it up to 30 liters, and I would wear the non-rebreather, and I would walk 3.4 miles per hour for 30 minutes. And I was so strong before transplant. So one thing you learn before transplant, exercise, 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 because after transplant, as Susie talked about, I could do 0.5 for 2 minutes. I was that weak. But my goal was to do 3.4 miles per hour in the 3 months of rehab without oxygen, muscle memory. And I did it. I got strong again. One thing I learned was because I had gained so much weight, I had 30 pounds to lose before the transplant. I lost weight after the transplant, but then with the prednisone, boom, I gained 30 pounds. So I needed to talk to a dietitian about eating, and I ate more plant-based meals. And yes, the protein, eating the protein. It was so important to do that. So I just felt like it was important to eat healthier. And so after losing the 30 pounds, I decided, hey, I'm getting older. I want to lose 20 more pounds and be at a good BMI. So I felt that really helped me. And I know prednisone does cause weight gain, but I've been a mentor at Barnes lung transplant program for 13 and a half years. And I see so many people use the prednisone card to gain weight, gain weight, gain weight. And I don't feel like it's honoring your donor. I just feel that way. I feel like you need to take care of your lungs, your body, to take the best care of yourself. And that means staying at a good BMI. I definitely changed my eating habits. And then you have to think about it after transplant. If you gain a lot of stomach weight, which is easy to do with our meds, I call it the Prograf stomach. You can call it the Pred stomach, but it pushes against your diaphragm, which causes more harder to breathe. And because I mentor down there, I've seen so many patients talk about, oh, I'm surprised I did lose a bunch of weight and my pulmonary function tests were better. So you never know. You just never know. And I'm talking about at post-transplant patients. So I am just passionate. Every mentor meeting I talk about is please take care of your body, eat healthier, talk to a dietitian, exercise, exercise, exercise. Amen.
Thank you, Marla. That's wonderful. Now, please welcome Lisa, who will share her thoughts on innovations in transplant and mental health considerations.
All right, thank you, Karen. So, a couple of things though about my history I just want to mention. Like Karen mentioned that I had my first pneumothorax in 1986. And then after I had three of them, pulmonologists did recommend pleurodesis. At that time, like many of us, I was diagnosed with bullous lung disease, right? So at the age of 19, I wasn't thinking about what my future was going to be like or that I could be limited by anything or the significance of this pneumothorax and this pleurodesis. But what that pulmonologist did do, which I find interesting looking back, she actually saw that three of my cysts were really large and she actually clamped them. And I think that actually, in hindsight, helped me from having more recurrent pneumothoraxes because we do know that the larger the cyst, the more likely it is to like rupture and lead to a pneumothorax. So I thought that was actually kind of innovative and interesting back in 1989 when I ended up having that pleurodesis. But then, like, I just went on with my life, still sort of like, oh, bullous lung disease, whatever that is. It just means I have cysts on my lungs, not really thinking anything could slow me down until it was like the year 2000. And that's when, like, everything kind of came crashing down. So I had another pneumothorax on the other side. So this was like, oh, wait, why am I having it on the other side now? So right away, I just went in for my pleurodesis and a biopsy. And then that's when LAM was discovered for sure. And I remember at that time, I mean, there was nothing, there was no treatment. The doctors that diagnosed me didn't really even understand what was going on. I remember they told me my pathology slide had gone from lab to lab because nobody knew what it was. So all they said to me was, oh, you're going to need a transplant. And I'm like, a what? A who? What are you talking about? You know, so that sort of sent me for a loop. But um, I kind of managed for another 10 years in this time. During that 10 years, I actually went to NIH a few times, which was amazing for information and also for them to get our data. And I remember during that time having a big discussion about pregnancy because, you know, that was what my husband and I were looking forward to. And then I got this LAM diagnosis and we didn't really know how those all connected. But anyway, I went ahead and had a couple kids. And then sort of my life, you know, was going on, but then boom, it came to an end in about 2011. And that is when my whole like life processes changed. That's when I had to go in for transplant evaluation. So in 2011, um, I'm living in Davis, California, which is very close to San Francisco and Stanford. And so basically it was like my health insurance, I could pick what transplant center I wanted to go to. So I looked at both of those, and UCSF said, we'll take you, double pleurodesis, no problem. We'll be fine. So I went ahead and went with UCSF, and I went through the multitude of tests. Literally, they gave me like an 8.5 by 11-inch piece of paper with just a listing of tests that you have to do. You are monitored from head to toe, or evaluated, I should say, from head to toe. You know that if there's going to be anything else wrong with you, they're going to find it. And luckily for most of us with LAM, there's nothing else wrong with us except LAM, but it's a doozy, right? So there's nothing else wrong. But I did have high antibodies. And when you have high antibodies, it makes it harder to match a donor because you actually have to find somebody that has the opposite of what you are high in. And if you're high in all these antibodies, it causes a lot of rejection and problems down the line. So I had high antibodies. So at this point, the way that you are listed for transplant at the point where I was under a different system that is available now. And I was under this lung allocation score, or LAS. And it didn't really take into account, there was a lot of biases actually in this old system, biases against women because women are usually the ones with the higher antibodies. Um, and biases against people with smaller lungs. Like women had high antibodies and smaller lungs. So it was kind of like a double whammy against women. The system has changed now, and I'll tell you a little bit about that in a second. But because I had high antibodies under that old system, I was encouraged to double list. So I was listed for transplant at UCSF in San Francisco as well as UCLA. So I would fly down to UCLA and meet the surgeon and all that. And it was whoever got a match first because it was very difficult to match. And my lung allocation score stayed low because I only had lamb. A doozy, but I only had lamb. So I wasn't like sick enough to get a lot of points, even though I couldn't breathe. And my lung function, my FEV1 was at 17%. You know, I mean, so that's not sick enough. So anyhow, like Karen said in the beginning, I waited almost 3 years. It was 1 month shy of 3 years. And I finally got the perfect match. So, that was in February of 2014, and I was 47 years old. I'm 59 now, so I'm almost 12 years out. I'll be 12 years out in February. And really, for me, life post-transplant it's been relatively uncomplicated, except for I have had a battle with skin cancer. And going back to the medications that Susie was talking about, the tacrolimus particular, there's also a medication called voriconazole that some of us get put on that is an antifungal. These all are high risks for, oh, and Cellcept is another one that I was on, but I'm off now. But so it all goes back to these drugs. Another huge side effect is skin cancers. I've had a lot of Mohs surgery. I'm like on first name basis with the Mohs surgeon now. I go in a lot. And so that is one thing that if you think that transplant might be in your future, sunscreen, hats, everything. We didn't know. All my activities were outside and we didn't have sunscreen growing up in the 60s, 70s. I don't even know if we had in the 80s. I think we used that one that smelled like coconut that everybody wanted to smell like a coconut. So no sunscreen. So if you know you're going to have a transplant, seriously, stay out of the sun is best. Sunscreen all the way. Don't worry if your face is white. I go out now and my face is white because I use all those really thick zinc sunscreens now. But so basically, because of that, I follow up with a high-risk dermatologist every 3 months. And then I follow up with my UCSF transplant team twice a year. One of the appointments is just pretty simple, kind of you just do breathing tests and labs. But on an annual basis, when I go in, it's a full workup. It's tests like CT scans, EKGs, echocardiograms, a lot of blood work, bone scans, pap smears, ophthalmology appointments or an eye doctor, dental appointments. They want everything done at those years because they just want to see if anything pops up. And that's what you want. It is kind of a pain, but I've made it a routine into my life. And that surveillance is to be seen as like, yes, I will do it, not like, oh, this is a pain, because they are looking for any little problem that arises immediately. So a lot of changes have happened since I've had a transplant. And one of them is now Anybody listing for a transplant as a woman with lamb with high antibodies, you are lucky now. You will not need to wait 3 years like I did. The CAS system that has replaced the LAS system, and the LAS system, I'll just give you a little history here. Before the LAS system came into play in 2005, before 2005, lung transplants were first come, first serve. Didn't worry, didn't even look at your health or anything. It's like, oh, you need a lung transplant? Here's the list. Oh, you're number 10. We're sorry that you're really, really sick and the people in front of you are not. But it was a first come, first serve basis up until 2005. Then the LAS system came in, and now the CAS system is in. And now you get points. You get points for long-term survival because we know lamb patients do really well. So you get a lot more points. You get a lot of points for antibodies. You get points for needing small lungs. You get, there's all sorts of things. So lamb women, we end up with higher points so that we're not waiting as long for lung transplants that I did. Also, let me see. The antibodies and stuff. So there's also some new, actually, I'm going to just, in terms of the surgery, they used to do a lot of lateral incisions, and then we went to clamshell. Today, they are doing lung transplants, minimally invasive surgical techniques. They're going in through the back with like 4 incisions. Recovery is much faster. Pain is a lot less. Infection is a lot less. It is amazing. If you are on a transplant list or thinking about it, ask your surgical team if that is a possibility for you, if your team is doing it. I know a lot of centers are, some are not. It really depends on the surgeon. If you've had pleurodesis, I'm not sure that that can work. That's what I don't know. The people with lamb that I've known that have had minimally invasive surgeries have not had pleurodesis. So that's something that I don't know about. The AlloSure test is another test that comes out that I don't get because I'm too far out of transplant, but usually if you're within 3 years post-transplant, it's a simple blood test that is actually measuring rejection and it's measuring free cell DNA of your donor in your blood. And it is a very fascinating test. It actually started in kidney transplants in 2018, and it expanded to lung transplants in 2021. And now Medicare actually pays for AlloSure tests as of 2023. So this is an amazing test. They have reference points of how much donor DNA should be in your blood. And if yours goes up, it tips your team into saying, hey, something's going on. Let's check a lot deeper into this. This is a non-invasive, super simple way to look for rejection. The previous way of looking for rejection was through a bronchoscope. You'd have to go in, you'd have to get put on twilight meds, get the bronchoscope, have a driver, you lose a whole day. This is blood work. This is a fantastic innovation that is available now. And they're looking at using it for people further out of transplant, but they don't have the data points yet. But certainly if you're within the first few years, it's absolutely an amazing one. The last thing, the one thing I skipped, I'm sorry, ex vivo lung perfusion is basically, sometimes people refer to it as lung in a box. And this is where when you're about to have your lung surgery, the lungs get put into this machine that is pumping blood and oxygen through the lungs. And so they can stay in there a lot longer than the old days when they had to take them out of a donor and put them on ice and then get them to a recipient really quick. So what's happening is we can actually probably get to the point where we're scheduling lung transplants. Like, for instance, someone got a call for a lung transplant and they said, this is great, go have dinner, come in tomorrow morning at 7:30. Well, not only is that great for you, but also your surgeons get a good night's sleep as well. And we're not doing middle of the night surgeries anymore. And they also use that to rehabilitate lungs that might not be great coming out of a donor, but they could rehabilitate them and then use them for transplant, which there's such a shortage of lungs available that this is a possible way to get more people transplanted. All right, I'm going to wrap up, but I just want to say, go to the next slide, please, Karen. I just want to say, like, anxiety and depression are like real things here. When you get put on a lung transplant list, if you're already not dealing with anxiety or depression, it seems that over 50% of us, once we get on the list, start having symptoms of depression and anxiety. And this is the important time to like reach out for help, get help. Your transplant outcomes can be affected if this depression and anxiety does go untreated. Actually, a UCSF team um, published a study in 2022 that showed there was much higher increase of mortality and rejection of those patients that did not get their depression and anxiety treated while they were on the wait list.
Wow.
And so, we can go through a lot of things to solve that, but you got to find what works for you. Therapy, social networks, meditation, visualization, whatever. But that is really an important piece of the pie that I think has been overlooked a lot. It's not really an innovation, but I really strongly encourage you to take check of your mental health issue. So, thank you, Karen.
Lisa, thank you so much. That was excellent. All right, Rhonda will be now talking about her case study as a lung transplant patient. So Rhonda, you have the floor.
Okay. I'll start off with the fact that I live in Wyoming, and I'm just going to give you a general broad brush of my transplant journey. So, living in Wyoming, we have no transplant centers here. And so I made my initial consultation with St. Joe's in Phoenix when I was at an FEV1 of 28%. I was always curious of what people's numbers are, and so I threw that in there. By the time I was listed 6 months later, my FEV1 was at 24%. And I ended up with about a 28-day wait down in Phoenix. I chose a transplant center 1,100 miles away from my home in Wyoming because there are no centers here. And I based my decision on Phoenix because my father-in-law lived there. We would have family. And also based on the ratings of the transplant centers and the scientific registry. So there's a website, it's srtr.org, that rates all the transplant centers if anyone is curious. And so we knew going into the process that the center was going to require us to live close in the area for at least 3 months. But given the follow-up requirement of the appointments and stuff, and the fact that it was a 2-day drive for us, we planned initially that our stay away from home would be 6 months. So I went into transplant strong, and within exception of bad lungs, I was healthy. I'd heard stories of other Lammies at the Lamb Foundation education opportunities where everyone was getting up and walking the next day, and I expected that would be me, and I was going to breeze through this. And my hospital center indicated that their average hospital stay for the patients was 10 days. I expected to meet or beat that as well, but that wasn't the case for me. I had a pretty rocky start. After being closed up from the initial 6-hour surgery, I had internal bleeding and was soon back in for a second surgery to deal with that. After the second surgery, I was kept sedated with my chest open for another day before I was closed up. And then I wasn't able to directly come off the ventilator and instead was trached for another period of time. And when you're trached, you can't speak. So that was not a comfortable situation to be in, and slowed things down again. But then the other main issue for me was I suffered from delirium. I don't remember delirium in the education that I'd taken. My transplant center warned of delirium because of the medicine is what causes it. And I for sure thought I was going to be exempt from that as well, but I was crazy as heck for several days. So, anyway, all in all, with all my setbacks, I was in the hospital for over 20 days, more than twice what the average was for my center. So, prior to transplant, I had heard stories of people being denied because of not having a caregiver. And after having transplant, now I know firsthand the importance of a caregiver. My husband was making medical decisions for me. He was the one that the medical staff could count on to calm me down when I was crazy. He was the one that was by my side learning post-transplant life with me. They dump so much information on you, and like you're not of good mind yet, that it took both of us to leave the hospital and be somewhat competent. He did my med boxes with me weekly for the first couple months, and initially, I mean, he definitely took the lead. He was my drill sergeant when I was tired and wanted to sit on the couch. And instead, we walked and we walked and we walked. And plus, after transplant, you can't drive for 6 weeks. And because you're still under the influence of meds, your chest is still healing. So you have to have someone taking care of you. And plus, he was the notification person. Social media, however you decide to set up, it's important to keep some kind of a notification system for your friends and family. And I love having the Lammies be part of the notification system because I know there's so many prayer warriors here. And I was thankful for every prayer. It's like I feel like I needed every one of them. And then also the importance of a secondary caregiver. Since I was so far away from my home, my husband, we had my brother go with us on the trip as a secondary person, which I mean, he gave my husband some relief sometimes. But at one point, my husband did catch a cold and had to leave our apartment for a week. So we really utilized having the second person there. So, and one of the first and worst things for me the first few months of transplant was dealing with nauseousness. And in the end, it was mycophenolate was the culprit for me, that once I was switched to Myfortic, my tummy issues toned down. And so anyway, someone mentioned that they can work with your meds and get you feeling better. So just be vocal about that, about how you feel, so they know what they're working with. And then Lisa talked about the lab tests that catches rejection before rejection. And at 1 month post-transplant, I had those labs, and it was showing high donor-specific antibodies. And so then I was immediately having plasmapheresis, they call it. They recycle your blood out of you. And then I continued on with IVIG treatments, which is basically just an IV drip that gets scheduled monthly, and it's about a 4-hour session. So it prevents rejection and giving up 4 hours a month for the treatments. I mean, I had to go through it basically 2 different times for 6 months at a time. But I mean, it was a breeze to do that. So, and all transplant patients generally have the 3 main rejection meds: tacrolimus, Myfortic, and prednisone. But as a LAM patient, I have a 4th anti-rejection, everolimus. And there's lots of us that are having everolimus, sirolimus added in. And anyway, I was at 6 months before they added that in. And it is balanced with my tacrolimus level. So Anyway, now I'm 7+ years post-transplant, and at this point, my journey has been mostly uneventful. I've never experienced rejection. My only complication has come from having COVID twice, which has resulted in drops in my FEV1, which at the time they take big drops. And then, after a few months, I can work up some, but I've never enjoyed, over 100% lung function like I started out with. And so, anyway, I have something less than that, but I still have great lung function. But getting sick is has taken a toll on my lungs. And so, anyway, and at this point, I'm sometimes amazed at the hustle I can show out on the pickleball court. And I just enjoy living an untethered life. Um, my transplant center referred to me as a quality of life case because my lung function was not so bad that I was, I wasn't going to die immediately, but I definitely wanted a better life. And I have gotten that for sure. As an out-of-state patient, I follow up in person with my center every 3 to 4 months. And then I do labs locally every 6. It started out at 6 weeks, and now that I'm past 5 years, I go every 8 weeks for labs. So I wrote my donor family a thank you letter at 1 year post and had no response back. I've had some disappointment in not knowing anything about my donor, but is more curiosity issue for me on general information like gender and age. And my center will not release even general information. And I know some people have general information. I don't know, for centers evidently aren't as strict as mine. But anyway, in one of the transplant groups I belong to, there was a conversation about, knowing your donors if they respond and stuff. And someone commented that if you hear nothing, accept it, because sometimes you find out information you don't want to know. So while I remain open to connecting with my donor family, I'm now more of the mindset of just accepting this magnificent gift and remaining grateful. Despite my rocky start and not really feeling back to par for almost a year, I definitely am glad I chose transplant.
Rhonda, thank you very much. That was wonderful. Thank you all. Our panelists have touched on many important aspects of post-transplant life. I recently read this quote from author Diego Perez, whose pen name is Young Pueblo, and I feel he could have been writing this to those on their transplant journey. To this, I'll simply add that transplant is a marathon, not a sprint. So let me just share this. Reminders when healing. Consistency counts. Patience over speed. Be gentle with yourself. It won't happen overnight. New habits equal a new life. There will be ups and downs. The seeds we plant will bloom. And now we will begin our Q&A. The chat box is now open for you to type in any questions you have for our panelists. Thank you very much. And ladies, the panelists, do you all have any other comments or questions to the other panelists?
I was just going to say, after 6 years of lung collapses, I was diagnosed in 42, and they told me, well, you've had it 10 years and you probably won't live, that long. So I started giving away stuff. Well, this week on Thursday, I'm celebrating my 70th birthday.
Well, when I was diagnosed and they looked at the chest CT scan, when I had my first collapse, they said, you have all these pea-sized cysts in your lungs, but don't worry about it. You have something called Bullous disease, me and Lisa, but never fear. Don't worry about it at all. 2 years later, same hospital, same surgeon. They did a biopsy, sent it to Dr. Moss, and that's where I got my diagnosis. So, you know, I credit the Lamb Foundation for getting information out to the thoracic surgeons about Lamb. And I think that really was instrumental in my getting a diagnosis only 2 years after my first collapse and my first pneumo. So,
Can I ask something?
yes,
Miss Karen?
yes. Welcome
Uh,
from Cyprus, right?
from Cyprus,
Yes.
yes. I make all the preparation now from transplant. I make all the exams that one of the girl they speak may tell us. I want to ask something. How long they told me in Greece I will make the operation, not in Cyprus. And they told me that they called me, and I I make my suitcase in case when they call me to
Right,
go quick.
right.
Uh, how long they stay at the hospital? Um, uh,
After the transplant,
yeah.
it really depends on the individual. From what I know, I'm starting to track that for the people who've had their transplants beginning this year. And I think here, roughly 3 weeks, 3 to 4 weeks, but it could be earlier and it could be later. I was in ICU for 5 weeks, just
They
ICU.
told me that I will make one and maybe 1.5 year because I will make a double transplant and also kidney transplant.
Right. Yeah.
It's difficult, the surgery that I will, the lung transplant I see, and also I make a research from the girl that they made a transplant, uh, and it's very good, the results. But the kidney, I didn't find research about the kidney for lung patients. If we have some girl who make a kidney transplant, I would like to uh, speak with them.
Right. Right. I understand. I understand. A year and a half for a lung transplant with a kidney transplant seems like an awful long time to be in the hospital to me. Um, uh, so that's a tough question. I hope finding the right donor would be important. Ladies,
Karen,
panelist.
I don't know. I've never heard. Oh,
I was just thinking when she said maybe the year and a half, maybe the physician, like if you just have a lung transplant, they do tell you to give yourself a year of healing, but that doesn't mean you're in the hospital. You're definitely in the hospital for your acute, like recovery, but then we, I got to move out of the hospital, but because I lived far away, I had to stay there for 3 months. Um, but then I was able to come home, and there's still like a lot going on in terms of testing and follow-up and stuff that first year. It's pretty intense. You don't feel very well because of all the anesthesia and stuff. You don't want to make any big decisions in that first year, I'll tell you that. You were kind of a little bit, you feel like your feet are on ground, but you're really not. And so sometimes I think when people they tell you it's going to take a year or a year and a half to heal, it might just mean total, and yours might be a year and a half because of the lung and the kidney. I mean, a kidney transplant on its own is certainly much easier than a lung transplant, but you're getting both, and I'm not sure if you definitely need both at the same time. So they have to coordinate that from the same donor, but it might be that your physician was just saying a year and a half total because you're having both things.
Yeah.
And that makes sense to me.
Right. Plus the fact that she lives in Cyprus, which is an island.
Yeah.
The surgery is going to be in Athens. So you can't just, if there's an issue, you just can't,
Yeah, you can't pop back and
take
forth.
the Uber over to Athens. So
Right.
Yeah,
maybe
it's
they want you to
difficult
stay
to
there
go
longer.
and come back. It's difficult to go and back quick.
Right. So I think that may
Yeah.
be part of it. So I'll have to think about that, Maria.
Okay. It's
Uh,
difficult for me because all of the people that I know that they make transplant, it's in USA.
Right.
In
Right, exactly. Let me, I see Kathy Pfeiffer, you have a question about the AlloSure test. Do you also have a bronchoscopy? I can just answer this. I've had many AlloSure tests that are, like Lisa said, just another blood test. You don't always have to have a bronchoscopy at the same time.
Right. My understanding is that if the test, depending on what it shows, that sometimes they'll do a bronchoscopy to confirm it. So that's what I was wondering.
Yes,
Oh.
correct. That's correct. That's correct.
Yeah.
If you've been having AlloSure tests and they always come back at whatever 0.1, and then all of a sudden it jumps to 0.9 or something, they're going to be like, all right, Kathy, come on in. We're doing a bronch, we're doing CT scan. They're going to do everything to find out what's going on because that's a lot easier to treat your rejection or whatever's going on right then
Yeah.
than to, you know.
Yeah.
Right.
I don't think Medicare does that test yet.
Who?
Loyola, I don't think they do that.
Oh, well, Medicare covers it now,
Yeah.
so I would ask about it.
Yeah.
And
it's a kit that's separate from the normal blood. I mean, they make a big deal out of it, at least at
Yeah.
my center, that, I'm like, I don't need you to mail it to my house. Just keep it at the center so I can pick it up when I'm going for my blood work.
so they send me a kit.
Okay.
They have. My numbers are kind of skewed. I'm kind of giving them data points but um, they send me a kit and I bring it in when I have my normal labs. And so the phlebotomist will draw the extra tube.
Right.
It goes back into the kit and you have to send it to the specific lab that that measures the cell-free DNA that they're looking for.
Right.
So it's your lab that you go to would draw like a reference tube, an extra tube, and give it to you. The tube is included in the kit. You hand them the tube, and
Right.
hopefully they'll draw your blood for you.
Right.
If not, there's a number that I call, and the phlebotomist came to my house once and drew my blood
Oh
for
my
the
God.
AlloSure test.
Wow.
I know, wild, but
Okay. Kathy, does that help?
Yeah, thank you.
Okay.
My
Hallie, you have
my center just does all of that when I'm there at a
Yeah.
visit.
is this at St. Joe's,
Yeah.
Phoenix?
yeah,
Okay.
yeah. It's pretty new, so I think maybe some, but it's the more we talk about it and let them know we want this too. So.
Definitely.
Someone asked a question about Ohio State. Is there anybody that had a transplant at Ohio State? Karen, do you know of anybody?
I have looked and I do not know anyone that had a transplant at Ohio State. But Hallie, you had a question about FEV1?
I do.
Oh,
Thank you,
FEV?
Karen. I'm curious when you have your annuals done, and I always focus on the percentage, the FEV1 percentage. And, pre-transplant, we're at 25 or 30% or whatever. Post-transplant, should we expect to be at 100% of predicted? Like, how do we know what a good number now is post-transplant? We know what a bad number used to be. What's a good number?
Mm-hmm.
Well, for me, because they had to scrape out my old lungs,
Me too.
and plus they had to trim the new lungs of my male lungs, I have averaged 75% for 14 and a half years.
That's good
And I
news.
feel great. I can walk
Yeah.
a 5K. I can't run it, but hey, I can walk it.
Mm-hmm.
Okay.
I would actually encourage you to look at the liters and not the percentage. Percentage can change when they put in different weights and like me, he claimed that my height was wrong. So he changed my height, which skews all my percentages. So I encourage you to look at the amount of liters. And you'll notice after a time, like I think most of us, when we first start doing them, they're kind of on the low, like they're lower, but we get a little better as we heal more and our chest isn't so tight. And then we can, as we keep doing them, just plot yours and you can see, and then you'll know, oh, that's a good one for me. Like I know now I'm good at 3 liters. And if I don't blow 3 liters, I'm going to do it again and again until I can blow that 3 liters because I'm going to get there. So like I have that goal in mind all the time. So what you do is just look at your past history, look at where your leaders are, and look at your stability. Where are you most stable? That's where you want to be.
Okay, thank you.
That's where you want to be.
Did any of us stay on sirolimus? I was never on it. And I know, Lisa, you were on it before transplant.
I did just have a discussion with a medical director at UCSF, and apparently they won't. So Dr. Dilling, actually, Dr. Dilling is the medical director for the Circle of Hope program. And he actually was very instrumental in this. But if you're on sirolimus and you get listed for transplant, your surgical team is going to tell you to come off of it because it interferes with wound healing. And because you don't know when you're going to have your transplant, they need that sirolimus cleared out of your system completely. So they can switch you over to everolimus, which has a shorter half-life. Thank you. And so what he was saying was Dr. Dilling actually went to UCSF surgeons and spoke with them and told them for women with LAM and explained about putting them on everolimus while they're on the wait list and taking them off sirolimus. And now they do that. So I think that if you are on sirolimus and you don't want to go off of it because you don't know exactly when your transplant's going to be and you don't know how far your lungs may drop, your lung function may drop, you can switch over to everolimus. However, if your surgical team says no, then this is where you call Karen and you say, Karen, we need Dr. Dilling involved with my transplant team to see if he can give all the scientific talk of why it's okay to be on everolimus while I'm on the wait list. So he's been doing that, and I want to give him credit for that because I just learned this the other day. So he works a lot behind the scenes for us as the medical director. So if you are one of those people and your team doesn't know about everolimus or wants to do it, see if we can't get a conversation going with the medical director of the Circle of Hope program to go on everolimus. Afterwards, they're not going to put you back on sirolimus for probably 3 months at least, or you got to go through the wound healing part. You can have it as one of your immune suppressants, or maybe you don't. I do. I have it as one of my immune suppressants. I think Susie, you do as well. Yeah. And Rhonda, are you on it, Marla, now? No. So you can see we're all different in our after care immunosuppressants. And it really just depends on like what Susie was talking about, what you tolerate, side effects. I had a lot of skin cancers. I used to be on different immunosuppressants. They've swapped me. Now they're swapping again, so it just depends. Everyone's going to be a little different depending on how you tolerate all these meds.
Do you have Miss Lisa, did you have a side effect from the sirolimus? Because they stopped me the sirolimus because the side effects that I have in my body. I was went to the hospital a long time from the side effects because I didn't I take some things that I didn't pee and they make they put me back to pee because I didn't for the pain. It was like herbs, but did not herbs. And the transplant surgeon told me to stop it before the surgeon, but I drink something now that they give me. It's one medicine, and they told me to keep it, and after the transplant, this the sirolimus, we are going to start it again after transplant.
Mhm.
Yeah, but not immediately after transplant.
Yeah, not immediately.
Usually, probably 6 months. At a minimum, 3 months, probably more like 6 months, but that's a call by the pulmonologist.
Yeah.
Okay.
Did you say, I'm sorry, so if I understood you correctly, you were on sirolimus, but they took you off because you couldn't pee. So it sounds to me like maybe your kidneys were involved. So there was some kidney issue.
And she's looking for a
No,
kidney transplant.
the kidney, it was good. And also the exam that they make me, but it was issue from the outside of skin, in the area there.
Oh,
And I see rheumatology also to give me the medication that I drink now. It's
mhm.
called Hikini, I think, that I drink now.
I'm not familiar with that one. Anybody? But yeah, I mean, there are many different medicines that do the same thing. So your
Okay.
team will find what you tolerate the best for all of your, yeah, for everything. Like for instance, I tried everolimus before and my liver function test went way up. So I can't
I
tolerate.
tried everolimus,
Or other
and
people can.
from the side effect, I went to the hospital. Almost I lost my life from the side effect
Hmm.
of
Yeah.
everolimus.
Yeah,
So luckily for
Uh,
us, there's many medications that can deal with a specific problem. So when you don't tolerate one, we can try another.
yeah,
That's
yeah.
that's
yeah.
and that's really all we can do is try one, see how it goes, tolerate it, don't tolerate it,
Right.
and then go from there.
Someone has asked about the survival rate post-transplant in lamb women. And the median average survival rate, median year is 12 and a half years for lamb
12.
patients.
Yeah.
Otherwise, for other lung patients, it's about 6 years. And could be for any reason. It doesn't necessarily have to do with getting the transplant. And as we heard from someone earlier, I mean, there are lamb women who celebrated 30 years post, 25 years post. So I think 50% at 12 years is fantastic compared to what the other people are going through, or potentially could have. So I'm not sure that that is a reason to be concerned. Some of it is a quality of life issue, right? I mean, do you all agree, panelists? Do you have an opinion on that? I mean,
Oh, being a
two
mentor,
of you are more than 12 and a half years out.
right, 14 and a half. I think a lot of it has to do with, since I mentor at Barnes, people following what the doctors say,
Oh, or
listening
not
to what,
following?
yeah, yeah, not taking their meds on time, um, living life. I mean, we had one patient who decided to swim in the lakes and rivers and didn't care, didn't wear his mask the first year. He just didn't listen. It's just really paying attention and doing what they say, the transplant team, and following following the protocol
Mhm. Mhm.
and
I would have to
exercising.
say that Marla is someone that I had listened to pre-transplant, and she talked about following the rules. And so I try to be a rule follower. And I mean, I think that's why we have better statistics. I know I had men at the same transplant center that I was at the same time, and neither of them are alive. And I know firsthand that they didn't follow the rules. So I don't follow every rule every day. I admit to that. But as a general, I try to follow the guidelines that are recommended for transplant patients. So.
Yeah, that. There's a question about how long do you have to stay on anti-rejection drugs post-transplant? Short answer, for life, right? That's one of the trade-offs. You're on it for life. And it can only help you.
Could I just say with that, Karen, when you first come out of transplant, you're on a high doses of all immunosuppressive drugs, and then you're on medications to sort of help with some of those side effects. But the further out you go from transplant, your immunosuppressive medicines, the dosages come way down. So it's sort of like, yeah, it's a trajectory in the downhill slide, which is good. And then you just get to sort of a very baseline level. You'll probably have one big change as you come down to 5 years, and 10 years they kind of went down a little bit. And then now they're trying to see again how this like AlloSure might be able to do more individualized medicine with people to see like maybe some people need higher doses of immunosuppressants and some need lower depending on the outcome of it. So there's a lot of like, again, like the whole innovations in transplant, I think are just really in our favor in helping us extend life with all the new medications and new testing and all these things that are coming out. But you can expect to be on them for life, but at different doses throughout your life.
Exactly. Question. I'm waiting at Toronto General and they haven't taken me off it. I guess it's sirolimus. I'm worried about wound healing after surgery. I would definitely bring that up.
Bring it
Who? Who asked that question?
Margaret?
Toronto General.
Margaret?
Margaret?
Yep. Can you see her, Beverly?
Hold on, let me make this smaller.
Hi, it's me. Yes, Margaret. Yeah.
Okay.
I'm in Toronto right now.
Oh yeah, hi
so-
Margaret. Yeah.
Hi.
Yeah, because I transplanted in Toronto. So I know the process. I don't see her, but that's okay. So who's your transplant? We'll get into the details. I can give you my phone number. You can call me, and I can fill you in. But so you're on the list. You've been listed. Margaret, have you been
Yeah,
listed?
she's muted.
She's muted.
Okay.
Beverly, why don't you go into the chat box and email Margaret specifically with your phone number?
Yeah, that's what I'm gonna do. Okay.
Okay. All right.
Where is she? Where is she? Hold on. Oh, I'll
Well,
find her.
everyone's screen is different, but
Yeah.
it's Margaret
Yeah,
Hawkins.
here it is.
Okay.
Yeah.
Okay, next
Yes.
question.
Mhm.
Any issues with silent acid reflux post lung transplant? Any thoughts on long-term issues with this? Panelists?
I just posted,
Oh.
if you notice a decrease, because you have your blowing machine, you should check it a lot in the beginning, but you'll see a decrease in your FEV1 if that silent acid reflux is affecting your blowing numbers.
Yeah, it definitely can be a problem because it can irritate the lungs, right? And can lead to rejection. A lot of centers will put you on a prophylaxis of something. Yeah, Protonix, Pepsid, what have you. You might be on, that might be one of, you're on medications for immunosuppressive, but then you're on other medications to help with other symptoms. But yeah, you're definitely most likely. I'm on one prophylactically as well. Although you can also have, what's that test called when they go down and check your acid?
Gastric emptying?
Is that what it's called?
Here they have the Bravo.
It's a really fun test, isn't it?
Oh, it's horrible.
The 24-hour test? Is that what you're
Yeah,
talking about?
yeah, 24-hour test with that NG tube. And
Ah.
like, yeah. So I forgot about that, Karen, but you're right.
Oh my
And they
God.
see
I
how
had
much
it twice. It
acid
was
you
horrible.
produce. And maybe if you're a lucky one and you don't have any, I don't know, lucky you. But I think most people after a transplant are on something prophylactically for acid reflux.
So I'm sorry, how do you know that you have silent acid reflux? Just your numbers on your daily spirometry?
You should show like a 10% decrease at least.
Okay. My question to the panelists before I move on, how many of you do spirometry, blood pressure, and weight every day and send that electronically to your team other than me? And Susie?
I do. I record those every day. I have a little chart, but I don't send them to my team. But when I have my clinic appointments, the doctor will look through the last few weeks or.
Oh, okay. Mine is an app on my phone that I submitted electronically so they can review it once a week.
Oh, interesting.
Yeah.
I have an app that sends it automatically, but I'm told to do it once a month.
Oh, okay. Well, you're out so far.
Yeah. Yeah. And again, that Susie, you record daily. Karen, you're closer to transplant. And of course you're going to do that. And then as things progress, they might say, all right, we don't need these every day. Maybe once a week, maybe once a month, maybe once every other month. Whatever.
Well, whenever I'm feeling badly, then I do it.
Yeah. I gotta say, I do forget. It's hard to remember something once a month.
Add
Can I
it to
ask
your
something
calendar
else?
as a to-do or an event. That's what I
Yes,
do.
ma'am.
I have
Yes,
another
mom.
one question about the transplant. If we make the transplant and also the body doesn't accept the donor's lungs, what happens next? How is the process like this? If they don't accept the body, the donors.
So what happens during rejection? Like if you're
Yeah.
rejecting, then what happens? Anybody?
Ladies?
I've never had dealt with rejection. I've heard that you go through that. I mean, I'm sure they probably look at your medicines and stuff, but I have heard about the prednisone treatments that people go through. And then there's also, is it photopheresis? That is sometimes an option. I think, Kathy, did you have some treatments for rejection?
Yeah, so there's different kinds of rejection. There's like right during the surgery, there could be rejection. I'm not sure what they do about that. But within the first year or so, you could have acute rejection. I had mine would have been in my second year, so about a year and a half or more. I had acute rejection, and that's where I was put on a prednisone burst for a month. So, and I knew, or I didn't know, but my FEV1 went down. It was getting more difficult to breathe, and so I had a bronchoscopy, and that's how they diagnosed the acute rejection. So for a month, I was on the prednisone. Had another bronchoscopy, I was back to normal, and then after that, I started having another decline in FEV1 after it had gone back to where it was. Had another decline in FEV1 and again, having more trouble breathing. And then I had a whole bunch of tests to see what else it could be going on. And everything was negative. So, and that was, I was in the hospital for about 5 days, I think, undergoing tests. And then they determined, because there was no other reason for this to happen, that I had chronic rejection. And then I was put on 2 medications, montelukast and azithromycin. And then I did eventually start photopheresis, which someone talked about plasmapheresis. I think it's similar in that they take out blood, not all of it, of course, some, and then add some medicine. No, they separate the blood out, add some medicine to the white cells, shine it under ultraviolet light, and then put it back in. And that's the only thing it's really proven to do is to stabilize someone. So I've been stable for, well, sort of. My rejection has been stable for almost a year. So that's what I'm doing for chronic rejection. Now, I did have a double fungal pneumonia last February, and so that put me my decline even more. So now I've been waiting now 6 months for a second transplant. And because of the anti-rejection meds, my kidneys, I have a chronic kidney disease, and I'm on the wait list for 2 lungs and a kidney, so that when they transplant my lungs, they predict that my kidneys will fail. They don't know, but there will be a kidney there ready to go from the donor in case. So not all rejection ends up like this. Even if it's chronic rejection, I know people that have been in chronic rejection for years and they're still functioning fine. But since I had a single lung transplant exactly 3 years ago today, my FEV1 never got above 50%. So when I started declining, the chronic rejection, or CLAD, took me to 30%. The fungal infection took me to 20. So,
Wow.
Does everyone know what CLAD stands for?
What's that?
Does everyone know what CLAD stands for?
Chronic lung allograft dysfunction. So it's another name for chronic rejection.
Okay.
So,
well,
there's a long answer, but
thank you.
Yeah, I
Carol.
have that too. I have that too.
Who's
Well,
that?
ladies, it's now 8:26 and we promised to end this session by 8:30. So it's time to wrap up. And before I turn it over to Cindy, a reminder that LAM research is predicated on our researchers obtaining lung tissue. The most common types of tissue contributed to research are lung, kidney, and uterine. Should you have an upcoming procedure or recently had a procedure such as a biopsy, please consider giving your consent for tissue donation with NDRI. Should you have any questions, you can please feel free to contact me. My email address is kkinsey@thelambfoundation.org. We appreciate all tissue donations. For more information about our Circle of Hope support program, please go to our website under Find Support and Circle of Hope. We would love to have you join us. And now I turn it over to Cindy.
Great. Thank you so much. Many thanks to our panel members, Marla Hamlin, Rhonda Officer, Lisa Pascal, and Susie Picard, for sharing your personal stories and offering encouragement and hope to our audience. And of course, a special thanks to Karen Kinsey for putting this evening together and for the important work that she does. So we are fortunate and grateful to have her on our staff. And to you all, thank you for joining us this evening. Thank you for staying with us. A recording of this session will be available next Monday, December 22nd. Our next Symposium in Your Living Room will be on Wednesday, January 21st, where Susan Jacobs will be presenting on understanding supplemental oxygen, device options, and tips for staying active. And as a complement to the Lamb Foundation webinar, Running on Air will be presenting an afternoon session on January 22nd, which is entitled Portable Oxygen Concentrator Basics and How to Spot Non-Centrators. So happy holidays to you all. I look forward to seeing you in 2026 for more Symposium in Your Living Room sessions. Have a wonderful rest of your evening.
Thank you.